This is Series 1, Pandemic, Public Health, and Structural Inequality. The core question that we ask ourselves in this series is, what did COVID-19 reveal about who's protected and who is expendable in global health systems? The abstract. This series examines how the pandemic exposed long-standing inequities in health, labor, and policy. Each essay traces how race, class, and geography shaped vulnerability, from frontline workers in overcrowded housing to medical mistrust and systemic neglect. It also explores resilience through community-led responses, the ongoing impact of long COVID, and the intersection of holistic and institutional care. Together, these essays argue that public health is inseparable from justice and collective responsibility. This is Article 4, Chronic Illness in the Pandemic's Wake, Long COVID-19 and the Lack of Research and Support, written and narrated by Jessica Vasquez-Luna. 5 years after the first surge of SARS-CoV-2 infections, long COVID has become one of the most persistent and poorly addressed public health crises in the United States. Millions of people now live with a condition that reshapes their ability to work, study, care for others, or maintain basic daily functioning. Yet, the institutions responsible for safeguarding public health, federal agencies, research bodies, and healthcare systems have responded with a level of inertia that borders on abandonment. The result is a growing disabled population forced to navigate chronic illness in a society determined to declare the pandemic over. Long COVID is not a fringe phenomenon. The World Health Organization estimates that 10 to 20% of individuals infected with SARS-CoV-2 develop symptoms lasting months or years. World Health Organization. These symptoms span multiple organ systems: post-exertional malaise, dysautonomia, cognitive dysfunction, microvascular injury, and immune dysregulation. In simpler terms, these are the kinds of symptoms that make everyday activities, walking upstairs, concentrating in class, standing in line, or even taking a shower, feel like they drain the body far beyond what is normal. A landmark cohort study published in Nature Medicine found that even mild or non-hospitalized infections can lead to elevated long-term risks of cardiovascular disease, neurological disorders, and metabolic dysfunction. Al-Ali. Despite the evidence, patients frequently encounter disbelief, diagnostic ambiguity, or outright dismissal when seeking care. This disbelief is not accidental. In fact, it reflects long-standing structural biases embedded in U.S. medicine. Long COVID does not conform to the acute care model that dominates American healthcare. Symptoms fluctuate, biomarkers are inconsistent, and no single test can prove the condition. These features mirror the diagnostic challenges faced by people with ME/CFS, fibromyalgia, and autoimmune disorders, conditions disproportionately affecting women, people of color, and low-income workers. Research in medical sociology has long documented how these groups are more likely to have their symptoms minimized or psychologized. Werner and Maltrud, Hoffman and Tarzian. Long COVID patients are inheriting this legacy of medical gaslighting. Research efforts have lagged behind the scale of the crises. While vaccine development received unprecedented investment, long COVID research has been comparatively slow and fragmented. The NIH's Recover initiative, intended to be the nation's flagship research program, has been widely criticized for methodological delays, limited transparency, and insufficient integration of patient expertise. A 2023 analysis in BMJ concluded that Recover had produced few actionable insights and had not yet translated its findings into effective treatments. Davis. For patients, this means years of waiting while their symptoms become entrenched and their lives contract. The economic consequences are equally profound. Long COVID has removed a substantial number of people from the workforce. The Brookings Institution estimated that up to 1 million workers may be missing from the labor force due to long COVID-related disability, BOC. These are not abstract statistics. They represent teachers, nurses, service workers, students, and caregivers whose futures have been rerouted by a virus that continues to circulate. Disability symptoms, already notoriously difficult to navigate, often deny claims because long COVID lacks a definitive biomarker. People are left without income, treatment, or institutional support. In the vacuum left by public health institutions, patients have built their own infrastructure. Online communities, mutual aid networks, and patient-led research groups have become essential sources of knowledge and care. The Patient-Led Research Collaborative, PLRC, composed of long COVID patients with scientific and medical expertise, produced some of the earliest comprehensive symptom surveys and continues to publish peer-reviewed research that outpaces institutional efforts. Patient-Led Research Collaborative. Their work demonstrates what becomes possible when lived experience is treated as legitimate data rather than anecdote. Long COVID forces the United States to confront uncomfortable truths about chronic illness, disability, and structural inequality. It exposes the limitations of a healthcare system built around short-term interventions rather than long-term support. It reveals how quickly society is willing to abandon disabled people when their needs challenge economic productivity. And it disrupts the narrative that the pandemic is a closed chapter. For millions, COVID-19 is not a historical event. It is an ongoing condition. A just response requires more than incremental research funding. It demands a reorientation of public health toward chronic illness, disability, justice, and patient-centered research. It requires expanding disability protections, strengthening workplace accommodations, acknowledging long COVID as a mass disabling event, and redesigning public health systems to recognize chronic illness as a collective responsibility. Most importantly, it requires listening to the people living this reality every day. Long COVID is not an enigma. It is a mirror reflecting the inequities that have always shaped American healthcare. What we choose to see in that mirror will determine whether we build a future where people are supported or one where they are left behind. The works cited in this piece are Al-Ali Ziad, Long-Term Cardiovascular Outcomes of COVID-19, Nature Medicine, Volume 28, 2022. Bach Katie, New Data Shows Long COVID is Keeping as Many as 4 million People Out of Work. Brookings Institution, 24th August, 2022. Davis Hannah E., Long COVID, Major Findings, Mechanisms, and Recommendations, BMJ 2023. Hoffman, Diane E., and Anita J. Tarzian, The Girl Who Cried Pain, A Bias Against Women in the Treatment of Pain. Journal of Law, Medicine, and Ethics. Volume 29, Number 1, 2001. Patient-Led Research Collaborative, Characterizing Long COVID in an International Cohort, 7 Months of Symptoms and Their Impact. eClinical Medicine, Volume 38, 2021. Warner, Anne, and Christy Maltered. It is hard work behaving as a credible patient. Encounters between women with chronic pain and their doctors. Social Science and Medicine, Volume 57, Number 8, 2003. And the World Health Organization. Post-COVID-19 Condition, Long COVID, WHO, 2023. Now we will be going into the author's cut, where we discuss inspiration, purpose, and ideas. For Article 4 of Series 1. Chronic illness in the pandemic's wake, long COVID-19, and the lack of research and support. So every time I revisit this essay, I do feel myself settling into kind of a seriousness that I wasn't expecting. It's not heavy in a hopeless way, but it's heavy in the sense of this is real, this is happening, and we still don't talk about it with the clarity it deserves. So this reflection is me kind of taking a breath before stepping back into the reality of it all. What pulled me into this piece was sort of frustration layered with recognition. It was almost therapeutic and kind of cathartic for me. So I kept hearing the same stories of people being dismissed, people losing their jobs, people trying to explain symptoms that didn't fit, neatly into a 15-minute appointment, whether it be in my research or talking to nurses, talking to people with similar experiences to mine. And I just realized that long COVID wasn't just a medical issue, it was a structural one. And it felt like watching a slow-moving crisis kind of unfold in plain sight while institutions insisted everything was fine. And that disconnect is what pushed me to write this piece. I needed to name what so many people were experiencing but weren't being believed about. So the idea that I was trying to explore was the collision between chronic illness and a healthcare system that was never designed to support, long-term fluctuating multi-system conditions. So this essay was my attempt to sort of map that terrain. So medical gaslighting, research delays, economic fallout, and patient-led innovation that are filling those institutional gaps. So I'm not in this piece I wasn't trying to solve anything, but I was trying to make visible the scale of what's been and currently being ignored. And I wanted to show how long COVID exposes the fault lines that have always existed in American public health. So, one thing I did debate including was a more personal angle, the emotional toll of, watching institutions fail in real time. And I went back and forth on whether to name my grief, my anger, and the exhaustion that so many patients carry. But ultimately, I kept the essay focused on structural analysis because I wanted it to stand as a clear, evidence driven critique. But part of me does wonder, what it would have looked like to weave in the human texture of that loss, not as an anecdote, but just as truth, as someone who has been dealing with this for nearly 2 years now and going through the ups and downs and still seeing specialists and being told that they don't really know anything about long COVID and there's just not enough research. So today, this essay kind of feels like a timestamp of a moment when the country was trying to move on and millions of people just couldn't. And it just reminds me why I write about public health and inequality in the first place, because silence is a form of abandonment and naming things is a form of care. So it also marks a shift in my own thinking. The moment I just stopped waiting for institutions to catch up and started acknowledging that patient communities are already leading. So this piece still matters because it's not just about long COVID. It's about who gets believed, who gets supported, and who gets left behind when systems prioritize convenience over care. So I hope that people feel seen by this, and I hope that it leads others to understand more about the condition and more about the effect that it's having in real time on society as a whole. And I just hope it sparks some sort of conversation and can maybe in the future lead to further research, further supports, and further support systems for patients. So thank you for listening and thinking with me, and I appreciate you being here. I'll see you in the next one.